It will be followed by a bout, so we'll just take Ahmad's talk in between and then come back.
So in fact, as of now, after the tonsillectomy, they're planning a bar. And most probably that Srinivas Kishore will be doing. So in the meantime, when the tonsillectomy is over, we can always have a couple of talks.
We can also have a discussion on what are the other options other than TAR.
That we will have the discussion. We'll leave it over there. And I understand exactly what you're pointing out. See, when you've had a look at the dice here, you have seen prominent lateral pharyngeal bands, and there was a concentric and also a side-to-side narrowing, side-to-side narrowing. It was not a classical antero-posterior narrowing. Bob and other things work very well for an antero-posterior narrowing, but when the minute it comes down to a bulky soft palate with a big edematous velar, and you see those are embedded tonsils grade 3, very badly fibrosed, and these are the type of cases where you see the AHI was almost 74 to 78 is what that has been told. Zeta would be a better option if in case you're planning to go in for a surgery. I know exactly what you're trying to put the options wise, but that has been planned out here, and let's see how they will go about and then do it when they compare, complete with the barked pharyngoplasty with an anterior palatoplasty. Maybe the result would be good. So without
question.
Yes, one.
Please go ahead.
They are planning to do a septum.
He said that in the beginning.
And a turbinate reduction too. They're going to show that also, turbinate. Yeah, please.
So welcome Dr. Ahmad. Dr. Ahmad is one of the young surgeons from Egypt. We've seen his work in the webinars over the 2 years. Now we are actually going to see him in person. Second generation ENT surgeon from Egypt, working at a tertiary hospital there, and does a lot of OSA work with a lot of airway work. So looking forward to hearing you on this topic of co-bout pharyngoplasty. Ahmad, please carry on.
Thank you. Good morning. I'm honored to be among dear colleagues and my professors, and thank you, Dr. Dipankar, for his kind invitation to beautiful India and Calcutta. I'm associate professor of otolaryngology in Alexandria University, and I'm consultant of sleep surgery at the same university. First of all, I'd like to thank Professor Claudio Vicini. He's my godfather. I consider him like that, and he taught me that technique many years ago. And of course, I would like to mention also my real father, Professor Yassin Bagat in Egypt, for his continuous support. I have nothing to disclose and have no commercial benefits from the coblation or nothing. So why coblation? The title is co-barbed, coblation, barbed pharyngoplasty. Why coblation? Coblation is a chemical process, it's not a thermal process. This yellow color is not heat, it's the sodium ions coming out from the dissociation of the saline that is forming the plasma medium, as Dr. Nakil said. And the idea of coblation is to make an energy to dissociate saline into sodium, the yellow color, the hydrogen to oxygen. You're going to find some vapor coming out from the wind. This is not heat. This is again results of the reaction. And the plasma medium, the free radicals coming out, and this will cause dissociation of the bonds between the cells and will cause cutting of the tissues, or you can use it as a capability to dissolute also tissues. So you can use it as like a debrider to remove tissues, and you can use it like a scalpel to cut tissues. It produces very less amount of energy, so that the heat generated by coblation is a byproduct. It's not the main idea to work with the coblation. So it's 1/10 of the energy generated by electrocautery, so minimal tissue dissolution and minimal penetration into deeper structures. We still now it's not well famous in Egypt to use the Hal1. We still use the EVAXL influent. We use the extra HP1, the high power one, that is 30 times more electrode life compared to the original one. And we don't use the coblation in this technique to perform stiffening like the cow technique. this is one of the techniques of coblation to be used in the palate, but it is used mainly for stiffening of the palate, not for making a pharyngoplasty. And the idea of most of cases of palate surgery now transformed from working on the central part of the palate by doing uvulectomy, radiofrequency ablation, or UPF or pillar implant. No, we are now working on the lateral part of the palate by doing expansion pharyngoplasty, relocation pharyngoplasty, or barbed pharyngoplasty. The idea of lateral pharyngeal wall surgeries is to produce such direction of scar. It's upward, lateral, and anterior scar of the lateral wall. No more scarring in the palate. The scar will be on the lateral wall, and it will work with you with time. And the main lateral vector of enlargement, it's unlike UP3. UP3, there is more central work of the scar to the midline. So now the picture changed from having such, we were searching for such beautiful scar in the past. So if you find this scar in the middle, you are happy and your patient is okay. But now we want to see this scar in the lateral part of the palate, not in the midline. So this is the idea of working with the barbed pharyngoplasty, is to take the lateral wall and the lateral wall muscle, the palatopharyngeus muscle, and to relocate it superiorly, laterally, and of course anteriorly towards the pterygomandibular raphe. That is a very good suspension structure. We start by doing coblation tonsillectomy. As Dr. said, the idea of coblation is it's quick, almost bloodless, and if you are going to work on a multi-level setting, it will produce less edema. At the end of the surgery, you're going to find less edema in the palate, so you can work at the tongue base at the same time, and you can work on the nose at the same time. So we perform tonsillectomy. A very small trick to do. This is one of the first cases. Please put a piece of gauze like that on the posterior pharyngeal wall, and put another piece of gauze on the uvula, so you're gonna protect the uvula and posterior pharyngeal wall from the suction and from the trauma of the coblation. And you can work, and you preserve the whole mucosa of the anterior and posterior period. Don't do such small traumas. Then, after removal of tonsillectomy, Tucker Wilson and Stuart McKay described the advantage of the presence of supratonsillar fat. If the patient is, especially if he's not tonsillectomized, and if he has no tonsils, and if the patient is obese, you're gonna find a very good amount of fat. It's maybe the same as the volume of the tonsil itself. So when we remove the fat, we remove another obstacle between the palatopharyngeus muscle and the pterygomandibular raphe. And then, when we remove these two obstacles, we can advance the palatopharyngeus muscle, the posterior muscle, to the pterygomandibular raphe. This is the second step. We use the coblation in order to weaken of the palatopharyngeus muscle to allow it to mobilize superiorly. This is a step at the lower part. And the step at the upper part, we use the coblation to ablate the fat of the supratonsillar area. So we just retract the anterior pillar, and we use the coblation as the eating capability of the coblation, like a rebridle, and we ablate the fat. So after doing tonsillectomy, we do two steps: just weakening of the muscle at the lower part, and the removal of the fat at the upper part. And then we demarcate two landmarks. One in the midline between the hard palate and soft palate, and the second point is midway between the midline and the pterygomandibular raphe at a lower position. Not here, but here. This we demarcate these 3 points with the coagulation, with the blue pedal of the coblation. We demarcate 3 points, and these are the 3 points of entry of the barbed wire. What kind of barbed suture we use? The barbed suture is a thread, comes with barbs. So it allows us to pass the suture without needing to knot the suture, so it's a fast procedure. Also, being fast is important to avoid edema, to avoid more trauma, and to be able to work on different levels of the palate. We now use the Covidian suture because we found it has a stronger barbs, better than even the Stratifix coming from Ethicon, and this is an experimental study. They compared the Stratifix suture from Ethicon versus the V-lock suture from Covidian electronic, and we found that that when you apply more force on the suture, the V-lock suture tends to withstand more and more force over it, and that force comes out from eating, from speaking, from talking. The patient is continuously using his palate after surgery. You perform a very good surgery, and you are very happy with the result, and then after 2 days the patient starts to talk, to swallow, to drink, and a lot of suture effort, a lot of force over the suture is coming. So sometimes you can have extrusion of sutures if you don't have very good strength in the suture. We found that the V-lock can withstand more force than the Stratifix. The technique of barbed reposition pharyngoplasty has been published as a feasibility study in 2015, and in a multi-center study we shared by about 20 cases in that study in 2017, and there is a prospective randomized controlled study in 2019. Now we are publishing our 5 years experience on 100 cases in 2022. So the pathway of the suture at the end is, this is the maquette coming out from Professor Vicini. We start from here, the midline, as we said, going to the lateral raphe, passing through a midpoint at the middle. As we said, we remove the fat, we ablate the fat with the coblation, and we just a small cutting of the muscle, not complete cut, weakening of the muscle at the lower part, and we start from the midline to this point, midway between the midline and trigonomandibular raphe, then going to the laterally to the raphe, and then from the raphe to the tonsillar fossa, grabbing the muscle and going back to the raphe without making a knot. So we do that at least for three loops, as Marina just said, for 3 loops between the muscle and the trigonomandibular raphe, and we come back again to the palate. At that point, we usually ended the procedure, but now with Dr. Vikas Agrawal, I hope he's coming maybe tomorrow. He also described to go from one raphe to the other raphe to make like a suspension between the two trigonomandibular raphe, and finally we trim the excess of the uvula if you have excess uvula. If you don't have excess uvula, then we don't touch the uvula. So this is a mountain space. The old space is the red one, and the green space you're going to find more expansion and more suspension of the lateral walls. This is to conclude how to perform after preparing the palate, after doing tonsillectomy, after doing the fat ablation and the cutting of the muscle and demarcation of the suture. We enter from the midline to this point, and then to raphe, and then to the muscle. We grab the muscle, we exit submucosally. Maybe the first suture, we take 2 sutures, but then we take just 1 suture. And as you see, you go from the muscle to the trigonomandibular raphe, you pull. You don't pull too much to avoid ischemia of the muscle and to avoid excessive traction of the muscle. You just pull, and whenever there is gapping, you continue to take more sutures until you satisfy that the lateral wall is completely sutured to the trigonomandibular raphe. Again, don't pull too much to take the muscle to the raphe. It will come with you with more sutures, at least 3 sutures. You see, you take the part of the muscle close to the uvula, and then to come back again to the raphe, and from the muscle to the raphe, from the muscle to the raphe. So you can imagine if you are working with just simple sutures, you will take a lot of time to do such results. And I don't know if you can feel the tension that you acquire on the lateral wall. There is more expansion of the posterior wall. Posterior wall of the palate, and if you can feel the anteriorization of the palate anteriorly, and the superior mobility of this area from here to there, and at the end we take the suture from one trigonomandibular raphe to the other trigonomandibular raphe to keep the palate away of the posterior pharyngeal wall, and do the same on the other side. And at the end we just cut the muscle, and that's it. We don't need to take any sutures. This is a picture, pre-operative picture, just before surgery. This is the collapse of the lateral wall, and of course the whole palate is collapsing on the posterior pharyngeal wall. And here's the picture immediately after doing the barbed pharyngoplasty. Very wide space, retropalatal space. This is a picture 1 month after surgery, and you can see the scar is on the lateral wall, no more scarring in the midline, and the very nice space 4 months post-operative. So the idea of the coblation to make it quick, less bleeding and less edema of the palate. You can remove the tonsil, the fat, and the cutting of the muscle at the end, at the beginning. And then the idea of the barbed is to be quick in suturing the lateral wall to the pterygomandibular refuge. Finally, just a reminder of major future events. We have the IFOS meeting next month in Dubai from 17th to 21 January. I invite you all to come there. There is a very good scientific program in the sleep surgery program, and we have a very strong course, the 10th annual course on sleep surgery in Orlando from 26th to 28th in next February. So I invite you all to also to attend. Thank you so much.
Wonderful. Very good presentation. And Dr. Ahmad, thank you very much for that. We have 4 minutes. And I have 2 questions, and we'll take 2 questions from the audience. The first question is, do you select your patients when you're doing this procedure, and what is that selection criteria?
Yes, yes, definitely yes. Patients with BMI less than 30 or 32 maximum are very good candidates for palatopharyngeal procedures. Patients with no skeletal, major skeletal problems, no highly arched palate, no significant retrognathia, so they are very good candidates. Of course, patients with bigger tonsils are very good results. Bigger tonsils, bigger palatine tonsils than with smaller tonsils. But anyway, even without tonsils, it will give very good results. Patients with not very severe obstructive sleep apnea, not more than 50 per hour, because if you have very severe sleep apnea, more commonly you have many sites of obstruction other than the soft palate and
pharyngeal phenotype, which one would you prefer?
Of course, oblique palate, not the vertical palate. That's one. And second, not very thick lateral pharyngeal walls. If you have very strong muscles in a very strong patient, sometimes the suture is not enough to hold that muscle. Sometimes we need to remove part of the muscle, like expansion pharyngoplasty or lateral pharyngoplasty, to remove that part and to embed it into the pterygomandibular effect. Not just to suture it like that, not just to cut the muscle and mobilize it.
What is the longest duration what you have observed your patients?
For some patients for 1 year, 2 years, and they are doing very good.
See, there are a couple of articles that talked in terms of the fibrosis of the palate that occurs.
Yes.
Has got a duration. After a particular time, be it due to natural changes, again the palate starts becoming a little more supple, not having the same tension.
Yes.
Have you ever noticed that over a period of time? And
when they gain weight, yes. Some patients.
when it get away, it does. But your follow-up is of 2 years.
Yes.
Wonderful.
Yes.
And any questions from the audience? Yes, please. We'll take 2 questions. Please. Dr. Navin, and then sir.
Do you use an absorbable suture or non-absorbable suture?
It's PDS suture, it's absorbable suture, but it is absorbed after 180 days, so 6 months.
So your follow-up is 1.5 or 2 years, that's what he was mentioning.
Yes.
So when you use an absorbable suture,
Yes.
then you can have a little...
No, this is a classical 180 day. This suture bar lasts for 180 days.
Yes.
And 180 days, slowly the tensile factor goes down and the fibrosis sets in.
No, but non-absorbable suture would give you an advantage, that is what I'm asking.
So
Yes,
I'll just come to that. Right? What is happening is now Professor Vichini is the one who's mentored most of us in BARB, including me. But we are now shifting from the absorbable to the non-absorbable. It's a little too early to be talking about it because it's just about a couple of months that people have started using non-absorbable. So give it another year or 2 and we'll know exactly what happens with it.
Hello?
Yes, please.
Hello, audience?
Yes, we hear you.